Good afternoon. My name is Neh Molyneaux, and I am a pediatric emergency medicine fellow at Kings County Hospital Center and SUNY Downstate Medical Center in Brooklyn, New York. I would briefly like to take the time to thank the Society of Academic Emergency Medicine for allowing me to present my research today. We have no financial interest to disclose. Neonates, defined as infants 28 days and younger, are high risk and pose difficulty in clinical decision making for most healthcare providers. This is primarily because it's extremely hard to look at an infant in this age group and determine whether they have an invasive bacterial infection, defined as meningitis and bacteremia, or a non-serious infection such as the common cold. Therefore, current management is recommended to be aggressive with full sepsis workup. This workup is done to rule out meningitis and bacteremia. This evaluation includes blood, urine, and cerebrospinal fluid testing, empiric broad-spectrum antibiotic administration, and hospital admission. Now, why is this important? As we all know, missed bacterial meningitis and bacteremia is associated with significant risk of long-term neurological sequelae and mortality. And 28 days is the age cutoff that many hospitals use for full sepsis workup, regardless of how the neonate appears clinically. Many studies have been conducted to define the best criteria to identify febrile neonates at low risk of having invasive bacterial infection. Although protocols such as step-by-step and Rochester criteria have been created to help identify low-risk infants, a significant number of these neonates are still missed and are found to have meningitis and bacteremia. Though distinction in age is very important, there is no single protocol for the management of febrile neonates that is universally adhered to across the United States. Therefore, the objective of this study is twofold. 1. To measure the prevalence of invasive bacterial infection defined as bacteremia and meningitis in neonates. And 2. To develop a low-risk tool for evaluation of febrile neonates by combining reassuring Rochester criteria, low-risk Yale observation scale score, and patient demographics. This study is a secondary analysis of data that included febrile neonates from the Febrile Infant Working Group subdivision of PCARN. The study population consisted of previously healthy febrile infants 60 days and younger between December 2008 and May 2013. All infants had a documented fever and were evaluated with diagnostic evaluation tests, including blood culture and lumbar puncture for cerebrospinal fluid culture. The sample excluded infants less than 37 weeks gestational age, infants who had antibiotics within 4 days of presentation to the emergency room, those with overwhelming clinical sepsis, chronic disease, or any other underlying illness. There were a total of 7,334 febrile infants, of which 1,524 met our inclusion criteria of age 28 days and younger. All of the neonates in the study had a blood culture, and 94% had a CSF culture. We use receiver-operator characteristic curve and decision tree analysis to determine if the operating characteristics of reassuring Rochester criteria, low-risk Yale observational scale score, and demographics were applicable as a combined screening tool for invasive bacterial infection. The Rochester criteria is a set of low-risk criteria used to identify infants unlikely to have a serious bacterial infection. The low-risk criteria include that an infant generally appears well, has been previously healthy, has no evidence of skin, soft tissue, bone, joint, or ear infection, and laboratory values that fall between a specific range for white blood cell count, absolute band count, urinalysis, and stool smear. The Yale Observation Scale Score was developed as a clinical score to help identify febrile children with serious bacterial infection. The score includes assessment of the 6 characteristics listed. For each characteristic, a child is given a mark of 1, 3, or 5 for normal, moderate, or severe impairment for a total of 30. A Yale Observation Scale score of 10 or less defines the child as well appearing. For the purpose of our study, the Rochester criteria was modified to conform with the data reported in the PCARN dataset. Rochester criteria defined low-risk urinalysis as urinalysis less than 10 white blood cells. However, we used less than 5 white blood cells as this was the cutoff reported by PCARN. Low risk for Rochester stool analysis was less than 5 white blood cells. However, PCARN did not report this result, so we used no history of diarrhea as low risk for this value. When values were missing, a more conservative approach was taken and was assigned low-risk values to maximize the inappropriate low-risk stratification in our decision tree analysis. In our study, meningitis was confirmed with a positive CSF culture, and bacteremia was confirmed with a positive blood culture. When looking at demographics, our results showed that the median age of our study population was 19 days. 56.9% were male, and 57% were white, and about a quarter were Black or African American. The prevalence of bacteremia was 2.9%, and the prevalence of meningitis was 1.5%. When we looked more in depth at age as a risk factor for meningitis, we determined that the optimal age cutoff was 18 days, meaning infants 18 days and younger were considered high risk in the study sample. We created a decision tree with application of our low-risk screening tool for identifying invasive bacterial infection. Our clinical decision tool combined reassuring Rochester criteria, low-risk Yale observation scale score, and age greater than 18 days to identify neonates at low risk for invasive bacterial infection. The next few slides will discuss the findings from this figure in more depth. Starting from the top, there were a total of 55 neonates of 1,524 diagnosed with an invasive bacterial infection. Of these, 11 had meningitis, 34 had bacteremia, and 10 had both bacteremia and meningitis. After applying the Rochester criteria to these 55 neonates, 24 were considered high risk as their white blood cell count was either less than 5 or greater than 15, leaving 31 neonates. An additional 6 were excluded due to a urinalysis with greater than 5 white blood cells. Of the 25 neonates remaining, 2 were excluded as they were noted to have a soft tissue infection, 2 were excluded for having diarrhea, and an additional 2 were excluded for having bands greater than 1,500. With Rochester criteria applied alone, there were 19 patients incorrectly considered low risk with invasive bacterial infection, 4 with meningitis, 12 with bacteremia, and 3 with both bacteremia and meningitis. After application of the Yale observation scale score of less than or equal to 10, an additional 4 neonates were considered high risk and removed from the sample, leaving 15 incorrectly categorized as low risk. Lastly, age 18 days and younger was found to be a high risk factor for invasive bacterial infection and excluded an additional 8 patients. The remaining 7 patients comprised of 6 febrile neonates with bacteremia and 1 with meningitis. We also wanted to determine the prevalence of invasive bacterial infection in our low-risk group. Of the 1,524 patients in the study, 456 neonates met our low-risk criteria. All had blood cultures, and 423 of them had CSF cultures. The prevalence of bacteremia in this low-risk group is 1.3%, and the prevalence of meningitis is 0.24%, which is lower than the prevalence of the entire population, with bacteremia at 2.9% and meningitis at 1.5%. This table describes the neonates missed using reassuring Rochester criteria, low-risk Yale observation scale score, and age greater than 18 days as a screening tool for invasive bacterial infection. The single neonate with meningitis that was missed was 25 days old and initially had an indeterminate CSF culture, which was later classified as growing enterococcus. The 6 patients with bacteremia that were missed ranged from 20 to 27 days of age. Blood cultures were positive for E. coli in 50% of these patients, with the remaining growing group B strep. None of the patients with bacteremia had a co-infection with meningitis. However, 2 of the 3 neonates with E. coli bacteremia had a concomitant urinary tract infection with the same pathogen. In conclusion, age greater than 18 days, not 28 days, is a low-risk criterion that, combined with Rochester criteria and Yale observation scale score, can identify infants unlikely to have invasive bacterial infection. Neonates greater than 18 days who meet low-risk Rochester criteria and have a normal Yale observation scale score, which is a score of less than or equal to 10, may be carefully observed on the pediatric inpatient unit without lumbar puncture and administration of antibiotics. These findings should be verified in a prospective study. Thank you.